Welcome to Program Planning and Evaluation, using evidence to develop effective programs. In this session, we will discuss how to use theory and evidence to create public health programs that work. We will start off by reviewing some commonly used theories. Then we will discuss the use of evidence-based programs, and finally, we will take the concept of the causal theory from last week and build on it to create an effect theory. First, just a few words about language. What is a theory? The authors of our textbook describe it as, quote, a description of how something works. Simple enough, right? A description of how something works. So what is the difference between the theories you and I create and well-known theories like social cognitive theory or the trans-theoretical model? They describe how things work. The difference is that social cognitive theory has been tested through research again and again, and these kinds of theories, the ones that we know well, are also usually more general in nature than the kinds of theories you and I create during the course of program planning. Both kinds of theories are important. The theories that we develop during the course of program planning make clear our assumptions and hypotheses. They help us make the implicit explicit. They are usually specific to a particular community or health issue. Theories developed and tested by others help us think about the problem in new ways and point us towards possible solutions. Research has demonstrated that programs with a strong theoretical foundation, meaning they use theory, are more likely to be successful. Also, don't worry too much about the difference between a theory and a model and a framework. People often use the terms interchangeably, though strictly speaking, a theory is explanatory and descriptive, whereas a model is only descriptive. And the term framework is used in a lot of different ways and usually refers to a structure with various descriptive categories and then relationships between those categories. But the point is, don't worry about the difference between these terms, and don't think that only famous scientists can create theories. Everyone creates theories every day. And in this course, we will rely on other people's theories and our own theories about how things work. You've likely studied some of these theories in other courses, and I won't go into great detail here, but I want to review just a few common theories that are used in the development of public health programs. First, the health belief model. It proposes that before adopting a health behavior, the person must believe they are at risk for a negative health outcome and that the health outcome is severe. They must also believe that the benefits of performing that behavior outweigh the costs. There are other things at play, like cues to action. If you were developing a new program, for example, to prevent asthma attacks among children by reducing their exposure to secondhand smoke at home, you might want to ask yourself the following questions. Do parents and other caregivers believe that their cigarette use triggers asthma attacks in their children? Do they believe that asthma attacks are a severe health problem? And do the benefits of quitting smoking outweigh the costs? And this answer might be different for a parent versus an occasional caregiver like a family member or a babysitter. You can see in this example that a theory might help you ask questions or look at a problem in ways that aren't necessarily obvious. For example, most non-smokers would say, of course the benefits of quitting smoking outweigh the costs. But if we put ourselves in the shoes of someone who is addicted to tobacco, we must ask ourselves, what do we gain from smoking? And what do we lose if we quit smoking? If our intervention doesn't address these realities, we might not have the desired effect. Now let's consider another theory, the trans-theoretical model, sometimes called stages of change. This model proposes that people move through various stages from pre-contemplation, meaning no recognition of the need for change, all the way to maintenance, the regular practice of a health behavior. It suggests that tailoring health education to the audience's stage of change helps them to move from one stage to another. For example, the kinds of health messages that might motivate someone to move from preparation to action would be different from the messages that might be effective to help someone maintain a healthy habit. This model calls on program planners to understand their audiences and to think about how ready they are to change. Finally, let's talk about social cognitive theory. This theory has a lot in common with other theories commonly used in public health. What is unique is the concept of self-efficacy, the degree to which someone believes that they can successfully perform the health behavior. Taking the previous example, perhaps a parent has tried to quit smoking in the past and has not been successful, leading them to believe that they are not capable of quitting. An intervention might be more successful if it addressed self-efficacy and equipped parents with a variety of skills to help them quit. After all, for most smokers, they attempt to quit many times before they are successful. Past failure does not guarantee future failure. There are many more theories you can use to inform program development. These that I've discussed are just 3. In fact, some researchers have been moving away from the use of single theories and instead have tried to identify common constructs across multiple theories. These constructs include intention, barriers, skills, attitudes, social pressures or norms, personal norms or self-image, emotion, and self-efficacy. When you are developing a new program, theory is one important source of guidance. Another very important source is evidence-based programs. An evidence-based program is one that has been rigorously evaluated, often using a randomized clinical trial, and then published in peer-reviewed journals. There are a number of different databases of evidence-based public health programs, many of which are listed on this slide. The Cochrane Guide and the Community Guide are 2 of the most popular, but there are many more. Using evidence-based programs prevents us from reinventing the wheel or starting from scratch. More and more, funders require the use of evidence-based programs because they want to see their dollars go towards proven efforts rather than the creation of new programs that may or may not be effective. Using evidence-based programs can also make evaluation easier in 2 important ways. First, you can borrow evaluation methods and instruments from the original research. Secondly, you may not need to evaluate outcomes or impact as rigorously because someone else has already demonstrated that this program works. This allows you to focus your evaluation on questions that are meaningful to your community. Finally, using evidence-based programs can help speed up the planning process and get you to implementation faster. Many evidence-based programs have been packaged in ways that allow for easy replication. There's sometimes a cost associated with purchasing a curriculum or licensing materials, but these costs pale in comparison to the costs involved in developing something from scratch. Now, once you've conducted the community assessment and you have a good understanding of the community's needs and assets, you draw on theory and evidence-based programs to figure out the best way to improve the health outcomes. And the interventions that make up your program then directly address the causal factors, the mediating factors, and the moderating factors. For example, if your community assessment revealed that exposure to secondhand smoke in children's homes was a causal factor for the high rate of asthma attacks, You might propose a smoking cessation intervention aimed at parents and caregivers. Or if the needs assessment revealed that access to affordable pediatric health care was a moderating factor, you might propose an intervention to enroll more children in the child health insurance program, or increase the number of high-quality pediatric healthcare providers that accept this type of insurance. You can see now why most programs include multiple interventions. Solutions to complex health problems are rarely simple. By addressing the issue through causal, mediating, and moderating factors, and by working at multiple levels of the socio-ecological model, you increase the likelihood of success. By drawing on theory and adapting evidence-based programs, you'll be prompted to think about the problem from a variety of perspectives and to learn from communities that have already made progress on this issue. In conclusion, I want to circle back to our earlier conversation about theories. I mentioned that some researchers are moving towards a more unified theory of health behavior change, and I want to share an example of this from my own research. This conceptual framework brings together key constructs from multiple theories to consider when developing programs for adolescent sexual health. I conducted focus groups with teens and young adults about dual method use, the combined use of condoms and another form of contraception. Dual method use is recommended for adolescents as a means of reducing unintended pregnancy and exposure to sexually transmitted infections. This framework guided my analysis of the data and helped me identify several areas of possible intervention, including self-image and emotions. The focus group data revealed that participants held a mostly positive image of people who use dual methods. They were described as smart, careful, and future-oriented. They also used words that conveyed positive emotions around dual method use, like confident, secure, peace of mind. These findings led us to emphasize these positive self-image and emotions in a new web-based sex education program we were developing. I think it's a great example of how theory can help you strengthen and refine your programs, and even guide your research questions. Now, most program planners don't have the time or the resources to conduct such extensive research at the beginning of an intervention. My situation was unique. This was part of my dissertation research. Nevertheless, there are many ways you can use theory to help shape programs. And without theory, I may not have thought to look for these important factors that influence adolescent sexual health behaviors. That's it for today. As always, feel free to contact your instructor if you have any questions. Take care.